who's doing what. Are we live? No, we are not.
Yes, I got it.
Have all the panelists
Yeah, we are
on?
live. We are live. Yes.
We are live? Okay, great. A very good evening to one and all who are present here, and I welcome you on behalf of YOSI to one more edition of the YOSI Journal Club. So we start by introducing the YOSI team, which consists of a very prolific governing council led by our president, Dr. Sonal Kalia ma'am, our vice president, Dr. Devakant sir, our secretary, Dr. Karan Bhatia, our treasurer, Dr. Avanish Upadhyay, and our joint secretary, Dr. Nilesh Kumar. This is also supported by an able body of executive members consisting of members from all around the country as well as outside. So the concept of the Journal Club is to learn and grow. It's a study in the practice of presenting a paper, interpreting a paper, and discussing the outcomes for young ophthalmologists. So especially in this Journal Club, we assess the existing literature. We go into the definition of the problem, the specification of the research question, the definition and selection of the variables and subjects, the selection of the research design, the analysis of the data, and finally the interpretation where we go for the Mary format. Speaking of the format of the Journal Club is actually very interesting. For a month-long process, a mentee is assigned a mentor, and an article from a subspecialty of their choice is chosen and is discussed between the mentee and the mentor over a month. On the final day, that is today, at the day of the Journal Club, they are also joined by 3 panelists and a research expert to sit, dissect, and discuss the article presented. So in the Mary format, the acronym stands for M for method, assignment, assessment, results, interpretation, and extrapolation. This gives us a step-by-step approach to reading the evidence in medical literature. Our YOSI Journal Club team is a very prolific one, led by Nupur Goel ma'am. If you are interested in presenting an article in the YOSI Journal Club, you can take a screenshot of this slide or write to us at yosi.journalclub@gmail.com. Over the past 2 or 3 years, we've had numerous sessions that started right from the year of 2020 or 21, where we had sessions on glaucoma, endophthalmitis, cataract surgery, and oncology. In 2022, we had a few more prolific sessions, including pediatric ophthalmology, oculoplasty, glaucoma, pediatric ophthalmology and retina, and we ended the year with refractive and cornea in December of 2022. We once again began the new season in March of 2023 with cornea. We went on to glaucoma in April, to retina in May, to cataract surgery in June, to uvea in July, oculoplasty in August. We had a biostatistics masterclass in the month of September that was graced by Dr. Vanati ma'am, who's the present editor of the Indian Journal of Ophthalmology. We had a glaucoma Journal Club in November, and that brings us back to the month of December, where we are going to discuss cataract surgery. So the article up for discussion this evening is comparison of long-term surgical outcomes of scleral fixated versus retropupillary iris in intraocular lens, and this is from the Journal of Experimental and Clinical Ophthalmology, and this journal has an impact factor of 4.3. Joining us as our research expert for this evening is Dr. Zain, who is a consultant ophthalmologist at the Khatib Eye Clinic and Perfect Vision Center in Mumbai. We are also joined by an expert panel consisting of Dr. Aarti Hera ma'am, who's based in Pune, Dr. Ashwini Kumar Behra, who's the founder of the Netrika Super Speciality Center, and Dr. Shomava Mondol, who's a vitreoretinal consultant at Sushrut Hospital. The mentor for this evening is Dr. Vanashri Nair, who's a consultant cataract and refractive surgery services at the Giridhar Eye Institute in Cochin. And a speaker or presenter for this evening is Dr. Shilpa Vasant, who has completed her MS in ophthalmology from the Seth GS and KEM Hospital in 2023 and is currently working as a senior resident at Shatabdi Hospital, Mumbai. My name is Anujit Paul, and I will be a moderator for this evening. Without further ado, we can begin with this evening's Journal Club. With that, I'd like to invite Dr. Shilpa to please share a screen. And once you're ready, Shilpa, you can begin.
Thank you, Anujit. I'll just share the screen right now. So to start with, I'll be presenting an article, a study article, original article from YD Clinical and Experimental Ophthalmology, which was published in 2021, which is the comparison of long-term surgical outcomes for scleral fixated versus retropupillary iris claw intraocular lens. It had an impact factor of 2.3. So to start with, secondary IOL fixation normally we use in conditions where there is inadequate capsular support or intraocular lens dislocation. So the main two categories of secondary IOL are the one we are comparing here, retropupillary iris claw IOL and scleral fixated IOL, although there is also anterior chamber IOLs and three-piece IOL placement in the sulcus which is used. So while making a choice between them, we keep in mind the surgical proficiency, accessibility, and the clinical features of the eye that we operate on. We have newer surgical techniques being developed for the implantation, although supporting evidence in literature confirming the superiority of any technique remains insufficient. So here, when a patient is planned for a secondary IOL implantation or an IOL exchange, first we look whether the anterior capsule is intact. If it is intact, we look whether the capsular support is adequate to allow an in the back implantation of the IOL. If it is not, we place a three-piece in the sulcus. If anterior capsule is not intact, we then look for sufficient iris tissue, which if it is present, we can go either for an anterior chamber IOL or an iris fixated IOL. If sufficient iris tissue is not there, we try to fix it by way of pupilloplasty. And we can, if it is getting fixed, we can give a try for iris fixated IOL, although that is not much done, or we will go for a scleral fixated IOL. So we'll be comparing iris claw and scleral fixated IOL in this session. A question in between. Which is the suture material used in SFIL implantation other than polypropylene, which supposedly has superior characteristics?
So you can go ahead with the answer.
Yeah. So the answer is Gore-Tex. Here, the rationale of the study is to compare the clinical features, surgical factors, and long-term treatment outcomes of secondary IOL fixation using conventional suture scleral fixated IOL and retropupillary iris claw IOL. We also identify the prognostic factors associated with the final outcomes of poor vision, corneal endothelial injury, and late dislocations. The materials and methods used are the study here is of a retrospective nature. It was conducted in two tertiary high-volume hospitals affiliated with YOSI University of College of Medicine, which is Severance Eye Hospital and Gangnam Severance Hospital. Sample population are the patients who underwent secondary IOL fixation between June 2014 and December 2019. So the follow-up had an average duration of 33 months. Inclusion criteria, although not clearly mentioned, are the patients who underwent secondary IOL fixation, SFIL or iris claw IOL at the two centers. Exclusion criteria is are those patients with low visual potential, like those patients having active vitreoretinal diseases involving macula, history of ocular perforation, eyeball ruptures involving cornea, or traumatic optic neuropathies. So the parameters which are assessed are the demographic data at presentation, clinical data at onset, including the ocular biometrics, the surgical factors, and from onset to post-operative months, we check for the best corrected visual acuity and the specular endothelial cell counts. Long-term treatment outcomes are also measured, like the degree of surgical induced astigmatism, absolute prediction error of the IOL, development of post-operative complications. So the surgical technique which is used in this study mainly is defined by the surgeon's choice. So the secondary IOL itself was chosen by the surgeon. Since it's a retrospective study, it was up to the surgeon to choose, and all the surgeries were done by experienced subspecialty surgeons. The main tunnel was scleral or clear corneal as per surgeon's preference. But mostly in iris claw cases, it is mostly scleral, rarely a clear corneal. Vitrectomy was done anterior or past planar route in necessary cases, and the dislocated IOLs were either repositioned and sutured, making it an SFIL, or exchanged with an SFIL or an iris claw lens. So SFIL cases were done by an anterior segment or a vitreoretinal surgeon, and the IOL haptics were sutured onto the sclera. The iris claw lenses, PMMA iris claw lenses were enclavated, and all surgeries were done by a single vitreoretinal surgeon as per mentioned in the study. So the main outcomes that we measure, the primary outcome is a change in the visual acuity, best corrected visual acuity over time, which is compared between the two groups and the baseline. The secondary characteristics is the endothelial density over time, poor long-term visual outcomes, that is less than 20/40, significant corneal endothelial injury, and redislocations and their causes. Statistical analysis here is done for comparison between the two groups by chi-square test and independent students t-test to study association of various clinical factors with the secondary outcomes. Logistic regression analysis was used. A p-value less than 0.05 was considered statistically significant. Another question, in which other scenario historically is an iris claw lens used other than secondary IOL fixations or IOL exchanges? The answer is phakic IOL. Results, we had a total of 395 eyes of 373 patients at the final end of the study. Median follow-up period was 31.5 months, ranging from 3 to 67 months. So first we take the baseline characteristics. Out of the total cases, 237, that is 60% was SFIL, and the rest 158 were retropupillary iris claw. Median age of the patient was 61.5. There was an overall male preponderance, most significant in the iris claw group. No significance is noted in the age of onset laterality, onset of BCVA, or baseline endothelial cell count. So first we'll consider the cause of the surgery. The most common was in the bag IOL dislocation of unknown causes. Among the known causes, the most common was that the first cause was around 56.2% of overall causes, that is half of it. Among the known causes, 9.6% of overall was posterior capsule or zonulo, that is intraoperative causes causing posterior capsule rupture or zonulodialysis. The second most common known cause was suture break of previous IOL. Treatment factors, once we compare, so when we compare the main incision location, the most common, that is 67% of the cases had scleral tunnel incisions, especially in the iris claw group. Clear corneal incisions were used mostly in cases where SFIL, in the SFIL group where foldable IOLs were used and sutured on. Small side port incision were used only in the dislocated IOLs for SFIL group repositioning. A wide range of adjuvant techniques were done in addition to this in 16.2% cases, like endolaser barrier, epiretinal peeling, etc., out of which pupilloplasty was done most significantly in the SFIL group. The rest were equal in both groups. Another main factor which had a difference was the duration of surgery. Although the median value was similar for both groups, around 49 minutes, average operation time was lesser for iris claw and more for SFIL. For SFIL group, the suture use was Prolene 10-0, which is the most common suture, followed by 8-0 and 9-0. So here, this is the outcomes of the surgery that we are comparing. The dotted line on top represents SFIL and the thick line represents iris claw. And in the bottom, gray represents SFIL and black represents iris claw. So let's go into the details of it. The four characteristics we mentioned are BCVA, corneal endothelial injury, surgical astigmatism, and absolute IOL prediction. So when it comes to the best corrected visual acuity, iris claw had a better BCVA with sustained from postoperative month 1 to 36 months. And even by the final follow-up, there were better results in the iris claw group in cases of vision. Corneal endothelial injury after first month, there was significant decrease in both cases. But postoperative month 1 and 6, ICIOL had higher mean endothelial cell counts than SFIL. But after postoperative month 12 to 3 years, it remained equal. So only there was a faster loss of endothelial cells in SFIL group, but it was comparative at the end. The eyes which developed significant endothelial injury belong to either group almost equally. In case of surgically induced corneal astigmatism, it was similar in the study in both groups. The absolute prediction error, that is the difference between the goal diopter of the IOL versus actual refractive error, it was significantly lower in the RP-ICIOL group in comparison to SFIL group. Now we come to postoperative complications. There was a greater overall complication rate for SFIL. In terms of redislocation, SFILs encountered suture breaks in 17.7% cases, while iris claws had disinclination rate of 10.1% only. There was also ocular hypertension and glaucoma management required significantly higher in the SFIL group. Factors associated with poor visual outcomes were shown more in the SFIL in comparison to iris claw, and those were mostly greater age of onset, surgery caused by intraoperative complications, past ocular history of vitrectomy, glaucoma surgery, uveitis, and surgically induced astigmatism more than one diopter. There was also one more thing to be noted. Postoperative dislocations were associated only with the laterality of the eye, that is left more than right, which will come back later. So now we go to another question. Which novel SFIL fixation technique named after a Japanese ophthalmologist negates the use of suture fixation with the use of a three-piece IOL? Yamane technique. So we come to the discussion to conclude what we went through the results. Iris claw lenses had better visual outcome, more favorable absolute prediction errors, faster visual recovery sustained over 36 months, shorter mean operation times, higher mean central corneal endothelial counts till 12 months after surgery. And scleral fixated IOLs had larger number of postoperative tilts or decentered IOLs, more suture exposure complications, more redislocations, and more IOP rise leading to complications and longer mean operating time. These are a few other studies which agreed with the study that we took into account here. But the sample size is still higher for our study, so I'm not going much in detail. It was a few, the comparison mainly is between the BCVA as well as endothelial cell count, etc. So the author's conclusion in this study basically comes down to better visual gains we see in RPC, iris claw IOL versus conventional IOL with no significant surgical astigmatism. So here we can conclude the fact that lesser absolute IOL prediction error in SFIOL might be more due to the difficulty in standardizing the placement and positioning of sutures in SFIOL. So also median operating time is same for both groups, but the mean operating time is more for SFIL because of the outlier cases. So complicated cases of SFIL would have taken more time, and also even the surgeons would have gone for doing SFILs in more complicated cases. So hence SFIL took more time. Severe endothelial cell loss and bullous keratopathy calls for better surgical technique, which reduces intraocular manipulation. Modern suture materials and techniques have reduced the incidence of suture break in SFIL cases. Left eye surgeries had an increased risk of dislocations, possibly due to the dominant right hand in most people and the obstruction from patient's superior orbital rim and nasal bridge. Severe and rare complications were similar in both cases. So to sort of conclude, iris claw lenses, although having an upper hand in the study, is limited by a lot of conditions, especially the conditions of the iris. Limitations, according to author's interpretation, retrospective design caused a lack of randomization in patient selection, which might have caused more complicated cases to go towards the SFIL group and easier, simpler secondary IOLs to be done as iris claws. There was ethnically homogeneous sample population. There was a selection bias. Severe cases included since it was a tertiary care center used as a sample population, severe cases had come as a referral, so hence there's a selection bias there. Merits of the study is the large sample size, expert level subspecialty surgeons, so the surgical acumen must have been better. Long-term follow-up. They have tried to overcome the limitations by way of maintaining similarity in demographics and patient characteristics. We'll go to another question. Name a few conditions where use of an iris claw lens is not contraindicated. The answer is pre-existing laser PI. The rest are all contraindications of using iris claw. Now we go to the Mary method. So the first method, the study question is well defined. Sample size here is ample. The study population, although inclusion criteria is not mentioned clearly, it is loosely understood. But exclusion criteria was well defined. Study period is well defined. Study methodology was of retrospective type. Assignment. Institutional Review Board of Gangnam Severance Hospital approval was taken. Study adhered to the tenets of the Declaration of Helsinki. Average follow-up period was 33 months, 152 cases, completing a 3-year follow-up. Process. The allocation of cases in the groups were not random due to the retrospective nature of the study. So selection bias for severe complicated cases, as the study was conducted in a tertiary care center, which we went through before. There was no masking or blinding, which was possible in this case. Confounding factors: all surgeries of iris claw lens group was said to be done by a single surgeon, while the surgery of SFIL group was done by various surgeons. So there might be a lack of uniformity in technique in between these two groups. Assessment: measurement of the outcome of the study's question is appropriate and accurate regarding the phenomena we seek in the study. That is, comparison between the two groups. Follow-up of participants are complete, and the outcome measures are not affected by the observation. Results: statistical tests seem to correctly estimate the comparisons in question and are allowing us to infer statistical significance for each of the variables that we consider. Higher number of cases, that is 79 more cases in SFIL group versus iris claw group, could have had slightly skewed the results towards the against the favor of SFIL group. Interpretation: sample population is an ethnically homogeneous group. Skewing of the sample due to severe cases chosen, lack of randomization of cases in the group. So finally, going to the extrapolation, the intraoperative and the post-operative outcomes can be fairly extrapolated due to the large sample size and the long duration of study. But we have only compared two techniques between the two groups, which is not the case in the whole world in most of the setups. The SFIL group can have much better outcomes if for the newer surgical techniques, which if it was included, or we could have added more groups devised as opposed to the conventional suture technique, which was the initial first technique and obviously has a lot of complications due to that. Geographical disparity due to lack of availability of modern materials and surgical infrastructure further differentiates the thing. So finally, we can conclude that SFIL and iris claw, the choice is not just when it comes to which is the best. There are other factors also which come into play. RPICIOL, so just to conclude the take-home message, the RPICIOL seems to be safe and effective option long-term follow-up against the conventional suture SFIL. Long-term study with good sample size, giving reliable, accurate results. Possible surgeon bias in the study in the iris claw group, operated as it is operated just by a single surgeon. Similarly, SFIL group has more number of cases, which also might have skewed the results. Only conventional SFIL technique was included. The newer technique does not come into consideration here, which might have brought down the complication rates way further. Inclusion criteria was not clearly defined, although well understood. Thank you.
Thank you so much, Shilpa. I think that was very lucidly broken down for the audience. We'll have a proper discussion on this, but for now, I'd just like to share my screen and to continue with the next part of this journal club. we'd like to go into the research aspect, that is delving into the statistical analysis of this study. And for that, I'd like to invite Dr. Zain Khatib, who is a consultant ophthalmologist at the Khatib Eye Clinic and Perfect Vision Laser Center in Mumbai. He's an expert in cataract surgery, LASIK, refractive surgery, and glaucoma, having completed his MBBS from the said GS Medical College in Mumbai and his MS from the Karnataka Institute of Medical Sciences, Humbli. He has also amassed a number of degrees, including DNB, FICO, MRCS, FAICO, and cataract, as well as refractive surgery. With that, sir, I'd like to invite you to share the statistical aspects of this study.
Thanks, Anujit. Am I audible clearly?
Yes, you are.
So let's look at the abstract of this article. If we just give a glance and someone just reads the abstract, it's quite evident that, it says that iris clip lenses in every possible way seem to be better than SFIOLs. And that is where, you shouldn't just go on the abstract, and actually you need to read the article in detail to understand, why that is so. So, firstly, to, give the article its due, they have a good, they have a very good documentation of medical records and follow-ups. They've got a good follow-up with everything. But let's start with the surgical technique methodology, and this has been emphasized by Dr. Shilpa as well multiple times, that the iris clip lens has been done by a single surgeon, and the SFIOLs have been done by multiple surgeons at multiple centers with techniques not properly defined. Okay, so they've just mentioned that they were sutured with 80, 90, 10-0. But what method, we don't know. Some use clear corneal, some use scleral tunnel, the size of the scleral tunnel, nothing. So, and if you delve into this further, you realize that the one surgeon, the single surgeon who has done the iris clip lens actually is the first author of this study who has a separate publication on iris clip lens publicizing his technique of doing it. So basically, this guy is a super fast iris clip surgeon who's published a technique, and he's talking about this one technique versus multiple techniques of SFIOs done by multiple surgeons. So there itself, you've got a very big bias. Okay, you can't compare groups like this where you have one expert surgeon doing the expert technique versus others which are ill-defined. So that was one important aspect. When you talk about the main outcome measure, which we talk about they're talking about the best corrected visual acuity between the groups. Fair enough, they've compared the pre-op BCVA versus post-op BCVA at different times. But nowadays, reporting any kind of visual acuity post-operatively for cataract or refractive surgery has to be done in a specific format, which has been published in Journal of Cataract Refractive Surgery, where one of the very important comparisons is seeing the percentage of lines that were lost pre-op versus post-op best corrected visual acuity. Okay, so that is something that is missing in this study. You've not seen the percentage of eyes that have gained or lost a line. Rather, they have just done the mean BCV and taken the percentages at different times, which is not complete. Then another miss I would say is measuring the uncorrected visual acuity post-op and comparing it with the pre-op BCVA, because they are talking about factors like surgically induced astigmatism and absolute prediction error, where you are considering how much of induced astigmatism and all is there. So you have to then even talk about uncorrected visual acuity post-operatively if you're talking about the other things, not only BCVA. So UCVA, again, not taking post-op UCVA is a miss in this study. If we just look at the statistical tests that were done, these are just some basics. So they've used the independent student t-test, where they have not mentioned whether the population was normally distributed, because the independent student t-test can only be used if the population is normally distributed. And if it was not normal, which there's a high chance this study may not have a not normal population, you have to use the Mann-Whitney test to compare independent samples, which was not mentioned over here. Again, to compare the categorical variables, they have used chi-square tests between the two groups. That's good enough. But if you're comparing the pre-op visual acuity versus post-op visual acuity in terms of categorical variables, as what they have done, then you need to use the McNamara test, which is more appropriate. And chi-square is good enough for comparing the two groups. So this was a little bit about the statistical part. The mean duration is 30 months on an average, but the range is very high, from 3 months to 67 months. Only 39% patients completed 3 years, out of which 45% were SFIOL and only 28% were iris clip lenses. So the ones who had a shorter follow-up, actually, we don't know how many of those were the ones that were, had a meaningful, significant impact. So again, too much variation in trying to analyze the best corrected visual acuity with such a big range. Okay, then, if you just look at the charts which show the best corrected visual acuity in the SFIOL group, why should the BCVA in the SFIOL group be worse than the iris clip after 1 year? After 1 year, they have reported that endothelial count was okay, no complications. If you see the complications, apart from suture exposure and tilted IOL, nothing else was significant between the two groups. Now, tilted IOL should get compensated by BCVA, right? Because your specs do compensate for a cylinder. So why should the BCVA be so much lower in the SFIOL group as compared to the iris clip, if at all, if there's no detachment or CME or any of that? So I definitely see a bias somewhere over here. Again, they've compared SI and absolute prediction errors, which according to me shouldn't be done with so much variation, because there's too much, a lack of uniformity. We don't know in the SFIL group how many were clear cornea, how many were, scleral tunnels. All that has not been mentioned. Lastly, regression analysis is good enough. They found in regression analysis that SFIOL has 2 times more odds of developing bad BCVA as compared to iris clip. But if you had to do the regression analysis properly, they should have done the regression analysis in the SFIOL group and seen what were the factors that caused worse visual acuity in the SFIOL group to say that it had such bad BCVA. So rather than saying that SFIOL was worse than the iris clip in SFIOL, what were the factors to have caused this bad BCVA? Whether it was some complication or whether the cases with tilted IOL had worse BCVA, those would have been much more meaningful. So to conclude, I would just like to say that the study seems very heavily biased towards iris clip lens, and the author definitely appears to have some sort of motive to kind of show that his technique of iris clip lens is superior to the SFIOL. So this is what I interpret from this study. Thank you.
Thank you so much, sir. I think you just blown the article wide open. BCVA was not that great. Yeah, BCVA not being great long term for SFIOL, despite the factors cited, is a matter of question. With that, I think
one
yes.
error I can put into is that the glaucoma part, logically, iris claw lens should have more glaucoma cases, because iris claw is in long term having the tendency of pupillary block, because it is very adjacent to the iris. Otherwise, in SFIOL, there is a clear gap between the iris and the SFIOL. Probably SFIOL is put in the normal IOL position, though there is no bag, but SFIOL usually put in the normal IOL position, whereas iris claw is put just adjacent to the iris. So the chances of glaucoma is more in the iris claw lenses. That is probably pupillary block glaucoma. But in this paper, they have shown that the glaucoma part is more in SFIOL group. I don't know what is the logic behind that. So that is also, I think, a source of error.
So, my view will be, I would like to differ on this point, Dr. Soumya, because it is nothing, not much. We have done a PI, no? We have done a PI, so there is a chance of fluing. So just because of iris, because of that, developing glaucoma will be less. Because of other factors, complicated surgery, because of many cases are PPV cases, many cases are drop nucleus, many cases of vitreous are, or maybe how long the vitreous will be there. So because of that, the glaucoma will be there. Because in normal cases, for example, what Dr. Khokar does in child cases, in pediatric cases, in those cases are because of iris retrofixation, the glaucoma, I don't expect because of that the glaucoma will be there. The other causes, they definitely will be there. SFIOL or PPV cases, complicated cases, that might be a contributing factor, because that is not uniform which cases SFIOL, that is just randomization. That might be the contributing factor. But age per se, just because we did a retrofixation of IOL iris claw will contribute to more glaucoma, will not be a cause, I think.
As because many surgeons don't prefer to do PI also in iris claw. So I have I have talked to many senior surgeons. They are very happy without any PI in iris claw, and they are not facing any glaucoma.
Retrofixation or anterior fixation?
Retrofixation. So probably PI is better.
Then तो iris Bombay होना sure है. Most likely हो सकता है, क्योंकि वो most likely it will happen because of अगर PI नहीं हुआ तो.
So just to bring to notice, I don't know if the others have read this, but this particular technique of iris claw, which this surgeon has done, is by using a visco cannula going through the side port and enclaving both the haptics at the same time in one shot with a visco cannula. So this person is an expert iris clip person, and he's published this technique. So that is something that you must know. It seems like a very fast technique from the other publication.
Right. I think shifting from a few negative aspects, let's move on to I'd like to invite Dr. Ashwini sir right now to speak about the positive aspects of the paper. Dr. Ashwini Kumar Behra has his interest in cataract and glaucoma, with his subspecialty interest in pediatric ophthalmology, strabismus, and neuroophthalm, with numerous publications in PubMed Index journals. He is the recipient of a number of accolades, including performed live surgery at OSOCON in 2023. He has designed the current logo of the Indian Neuro-Ophthalmological Society and won some awards in the Neuro-Ophthalmical Society, as well as the DOS Ophthalmic Oscar in 2021. With that, sir, you already are discussing a couple of parts about the article. I'd like to invite you to continue to discuss the positive aspects of this article.
To continue on the positive aspects of the paper, first I will say there is a large sample size in both the categories. First, second is a long-term follow-up, 2 to 3 years. Yes, there is drop of many cases after 2 years. There are significant drop in cases in case of iris claw lenses, and other normal factors like specular count that taken into account, and it is done by experts. What the important that outcome that I see is like time needed for iris claw is less compared to SFIL, which in my hand also same. So I agree to it. Yes, he is an expert. So there is always a bias because SFIL so many variations are there. Being said that SFIL or these surgeries are not routine, not like just like cataract surgery. So we don't do a day in day out cases. So if I master in one type of technique in SFIL, that still I will continue doing it SFIL. So that expert who is doing iris claw lens, so definitely will have a better timing compared to the these lenses SFIL category. Or the other aspect is they have noted better BCVA and immediate recovery in case of iris claw lenses. Specular count is not significant different in long term according to this paper. The most common causes where we know the reason, like the causes where these cases are operated are listed properly, like intrap complications, PCR or jugular dialysis, or previous failed SFILs, or past PPV or ECC cases or trauma cases. In those cases, these causes are noted. That's it. If I say the only positive aspect is this, being said that I will not go to the negative aspect of this paper, but I will say this should not be, according to this paper, we should not go and tell that iris claw is better than an SFIL surgery. Iris claw has its own demerits also, and the technique that he described, it is very difficult to master. Just one port viscocannula and doing that, it is very difficult to do. I do that also retrofixation in cases, so he definitely master. So we cannot, from this article, we cannot just because he says that it is less complication are associated with iris claw and SFIL is more associated with more complications. We should not go on that way. It is on expert's view, but yes, it predicts because of the large sample size, a long follow, and it says normal outcomes as described. So that's what I will say the best outcome of this paper. And already Jane told the bias is there. So when you know there is a bias, then you cannot find the positive aspect from that paper. Even if you find the positive aspect, you think in the mind, oh yeah, ye to pakka gadbadi kiya hoga kuch, ye gapla, because you see now after 2 years there is a dropout. How will you explain that? You cannot explain that. He's an expert in there. Let the same surgeon did SFIL, then that is a point. Okay, there is a master in SFIL. Somebody has done 200 SFIL and somebody done same 200 iris claw, and same surgeon in doing the both surgery. Then you might compare. So I think that is the only positive aspect. Thanks.
Very bluntly put, sir. With that, I think we are really breaking down this article for what it really is. With that, I'd like to invite Dr. Aarti Heda, ma'am. She has completed her MBBS, DNB, and FRCS, FACS, MRCS, FICO, and a lot of more degrees. She's currently based in Pune. She's the national coordinator for the International Society of Manual Small Incision Cataract Surgery. She's an associate editor at the Global Journal of Cataract Surgery and Research since 2021, and her interests include cataract, glaucoma, retina, cornea, and refractive surgery. And in her spare time, she's also a state-level chess player, dancer, and a painter. With that, ma'am, I'd like to invite you to further discuss the negative aspects of this study and put it into a bit more perspective.
Anujit, do I have to speak anything here? I'm actually thinking. So anyways, good evening, everyone. I would like to thank Dr. Nupur and Dr. Anujit for this wonderful opportunity and making me part of this wonderful discussion. Dr. Shilpa very well presented. And Zain has actually spoken most of the points which I wanted to discuss. So I'll thank him as well. And Ashwini, let's say, wanted to say positive, but started supporting the negative aspect of the paper. So let's say, let's come to the straight to the point. So for me, the study is like comparing oranges and apple. I somehow don't agree to this whole paper at all. Let's say we are talking about secondary IOLs. It would have been fine if they would have been comparing the outcomes of two types of scleral fixated IOL, like sutured IOL and the glued IOL. Or let's say comparing the two types of iris lenses, like anterior fixated and the retropupillary fixated IOLs. But anyways, since the paper is already published, let's discuss few more points about this. So yes, we all agree that the surgical method for the secondary IOL fixation was determined by the treating specialist according to his or her preference in this paper. We all will agree to this fact that the type of surgery has to be randomized. And we can't say that because I wanted to do this, I have done this in this patient. Maybe this point, they have explained it in their limitation, so we really can't discuss that much. Next, the iris claw lenses operations were performed by a single VR surgeon and who is supposed to be the expert, and the other SFIOLs were done by other various surgeons. So here we again cannot compare because here we are comparing the surgeons instead of the surgical technique. Let's say we are comparing a skilled surgeon and let's say we are putting let's say 4 or 5 surgeons in the second group. So again, this doesn't stand very well here. For me, the exclusion criteria are not very, very clear in this paper. When you see the table number 1, let me just try to share the screen.
Are you being able to share it now?
Yes.
Yeah.
So here, if you see, they have actually included the patients who had history of pars plana vitrectomy for retinal detachment done, for other retinal diseases, uveitic treatment done, glaucoma surgeries. So will this not have impact on the visual outcome? And most of these cases were part of the SFIOL group and they were not part of the iris claw group. So will this not have the direct impact on the best corrected visual acuity? That being their primary outcome of the paper. So we really can't say that the iris claw lenses did better and SFIOL was not as good as the iris claw when we talk about the visual outcomes. I don't know whether you all agree to me in this point, but we'll have discussion on this later. Next, when we talk about the endothelial cell count, the author says that in terms of the potential for endothelial cell injury, we observed significant decrease in specular endothelial cell counts after surgery in both the groups, particularly in first month of the surgery. Additionally, the iris claw group appeared to have higher mean central endothelial cell counts compared to SFIOL at post-op 1 month. In their surgical technique, they've said that the iris claw lenses had the scleral tunnel, and the SFIOL group, more than 50 cases, had clear corneal incision. So if in case they are doing a clear corneal incision and SFIOL is done, I don't know whether the incision size was 2.5 or 5.5. I assume that it has to be bigger. Otherwise, they can't put SFIOL there. Right. Will that affect the astigmatism and ultimately the endothelial cell count as well? Is the question we should think. Okay, so yeah, so other points, I think more or less I have said, yeah. So when we talk about the duration of the surgery, they have combined the SFIL cases with surgeries like pupilloplasty and other retinal surgeries. So definitely the duration of the surgery is going to be more whether the iris claw surgeon is expert or not, because you are additionally doing some extra surgery here. So we definitely can't say that the surgery duration was less in iris claw lens. Somehow I'm not convinced with this point as well. And when we talk about the IOL prediction error in SF-IOL, so what I understand from the paper is some patients for whom SF-IOL was done in past, let's say even after 8 or 9 years, there was dislocation or let's say the same IOL was put as SFIOL or what, I don't know, because nothing has been clearly mentioned. In that case, definitely there is going to be the prediction error. Right? Iris claw lens is not that you have put the iris claw lens for some other surgery. Let's say I have put there's a pseudo exfoliation case and I've put 3-piece IOL, just assuming that it might dislocate in future, and I will use the same lens to use as the glued scleral fixated IOL in future. So in that case, definitely the IOL prediction value is definitely going to differ. But iris claw, we are putting a fresh iris claw lens there. So I think I've summarized most of the points I wanted to tell. So according to me, yes, the paper is not very convincing, and we just reading the abstract and the conclusion and assuming that the iris claw lens is better choice than SFIOL won't be correct. Over to you, Anujit.
Yes, I think this is a really good point for people who are listening in, who just read the abstract and base their conclusions on, especially for these kind of surgical intervention cases where follow-up is done. A lot is involved in the surgical procedure, as well as patient factors, operation theater factors, surgeon factors, which play an important role. We'll have a discussion on this as well, but before that, I'd just like to move on with the rest of the presentation. So last but not the least on our panel, we have Dr. Shomova Mondol. He has completed his post-graduation from the Regional Institute of Ophthalmology in Kolkata, followed by his long-term VR fellowship at Sushrutai Foundation in Kolkata, and is currently in charge of the VR department in the same institute. I'd like to invite you to speak about the recent advances in this aspect that can be applied.
So first of all, thank you, Dr. Anujit and Dr. Nupur, for giving me this opportunity to having in the panelist. So probably after the introduction of all the panelists, I have the shortest CV, I think. So what happens is, as I am a VR from a VR background, so I should have the opportunity to do every possible secondary IOLs which are available in the market. So if I discuss one by one, so first thing I have to say that to all the newer surgeons who are listening, that no IOL is bad if you know how to place it. So even if I have seen AC IOLs by the older surgeons till now, the post-op results are fantastic. There is clear cornea and there is vision is just 6.6 or 6.9. So ACIOL is obsolete now. But if anybody is comfortable with ACIOL who don't have any access to iris claw lens, don't have any access to VR surgeon in any remote area, he or she might have continued to do ACIOL properly if he or she knows how to place it. So second one is iris claw lens and SFIOLs, which we are discussing. So iris claw lenses having a very faster result and very cheaper. So it is based for the high volume setups, and probably it is better in hands of anterior segment surgeons because you don't have to actually go inside the vitreous cavity due to the anteriorly manipulation you are doing anteriorly. But for SFIOLs, you have to go inside the vitreous cavity. So probably in VR surgeon's hand, SFIOL is better manipulated. So in SFIOL, there are multiple techniques. Previously, sutured SFIOLs are practiced, but nowadays there is a trend for in support of sutureless SFIOL. So usually there are two techniques which are practiced in I think the nationwide. One is Yemenite technique, which is their scleral pocket is not prepared over the conjunctiva. You have to cautery the end of the haptic of the multipiece IOLs, and the haptics are conjunctivalized in the long run. And another is, I think, X-knit technique, which are popularized by the Arvind people. So it is, we are habituated with X-knit pattern. There is also scleral flap is not required. You just exteriorize the haptic of the multipiece IOL, do a scleral tunnel by Alcon via Alcon side port or any 24 gauge needle or any MBR needle, and you have to tuck the haptic of the multipiece IOL. So scleral pocket is not needed there. And the recent advances is CMT Flex IOL, which is, I think, popularized by Dr. Niven. So probably I have done 5 or 6 cases of CMT Flex IOL till now, and the results are very nice. It is very stable. It is single piece, so that the rotation in the long run, which we are seeing for the SFIOLs, for the multipiece IOLs, it is avoided. So CMT Flex is till now the recent advances in SFIOL. So again, I am highlighting that no IOL is bad if you know how to place it. Thank you. I think I don't missed any point.
Right. Thank you so much, Ramavada. I think we'll move on to our monthly mentor for the month as well as for this evening. I'll just share my screen once more. So, last but not the least, I would like to invite the mentor for this month, Dr. Vanashri Nair ma'am. She is a consultant cataract refractive surgeon at the Greater Eye Institute in Cochin. Having completed her MS Ophthalmology from the Grant Medical College in Mumbai, she has completed her long-term fellowship in phaco-refractive surgery from Bombay and has completed her ICU and her FRCS exams. She has special interest in complicated cataract surgeries, topical phacoemulsification, and refractive surgeries, with a keen interest in teaching and transferring knowledge to young surgeons. In her free time, her interests include music, gardening, photography, which are her passions beyond ophthalmology. For the past 1 month, she has been guiding and mentoring our monthly mentee throughout this entire process. And I would like to invite you to just summarize the session, summarize the topic, and give your 2 cents on this entire conundrum.
First of all, thank you very much, Nupur and Dr. Anujit, for having me on board this month for the YOSI Journal Club. And am I audible well? Can you hear me properly? Yeah.
Yeah.
So to summarize, we had this interesting paper where the sutured SFIOL were compared with the retropupillary iris claw, and I'm sure we have two group of people here who are either doing SFIOL or the iris claw. And as Somo very nicely put that, each lens is good depending on, if you're able to place it well. and it'll do its wonders. Summarizing the article, I would say yes, definitely it was heavily biased towards the retropupillary iris claw lenses. But the good point being that the study was over a long period, it was over 4 years, and they included a lot number of cases, around 400 cases were studied and compared. 60% were SFILs and 40% were retropupillary iris claw. But 60% of the SFIL cases were I would say the more complicated cases were included in that group. So the point which Zain had raised, that why the best corrected visual acuity was not good after 2 years, is answered probably by that point, that the more complicated cases, like the ones where Parsthana vitrectomy was done for retinal detachment, or other cases, or even acute glaucoma cases, were more in the SFIL groups probably. So that answers the question. And to conclude, what I would say, that definitely they said that there is a faster visual recovery, favorable absolute prediction errors, and shorter operation time for the iris claw lenses. But not only considering this particular surgeon, who's claimed to be a very good iris claw expert surgeon, but even otherwise, we see that many of the surgeons do advocate and they are happy doing iris claw lenses. But having said that, there is definitely a role for SFILs, be it sutured or even the newer techniques. And depending upon the situation, which surgeon is operating, what is the operative availability in that particular hospital, the financial factors, and the requirement for that particular patient, I think will finally decide what needs to be done in the best interest of the patient, is what I would like to conclude.
Right. Thank you so much, ma'am. So, like I myself, I'm doing only sutured SFIs, because whenever we get a case of nucleus drop or some place where there's a PCR, the first thing that when we are called in as VR surgeons is that we start making me and we prepare the flaps, and then we go inside, we put a trocar in, and then we go inside and we start clearing everything. And if we see everything is fine and we can still put the multi-piece through the tuck technique or something, we go for that, or else we always keep the option for a sutured SFIL open. But it's interesting to see in this session that there are so many varying techniques among all surgeons that are equally successful. So shifting from the article and the theory aspect for a couple of minutes to the practical aspect. So we were having this discussion before we went live also. I would just like to ask every panelist as well as the monthly mentor on their preference, what are their 2 cents for anybody who's starting off, what would they suggest, number one. And number two is that what are the hurdles that they faced initially, what somebody starting off with either retropupillary or with SFILs should keep in mind. And number three is that if they have any aisle of choice, given that they have a good area to work with in their setup. So I'll start with Zain sir only, since we started with him. So just your experience, any tips and going forward.
Yeah, so I
From the
personally
practical
feel that, I personally feel that whichever lens you're doing, don't go by the videos which the expert surgeons show as very easy. The iris clip actually looks very easy in an expert person's hand. You will probably need at least 4 to 5 cases before you can start doing it comfortably. So you need I would say a formal training in these sort of surgeries. You can't just do a phaco fellowship or some anterior segment training and then start doing iris clip lens in private one day. So, or even a SFI, will be it any technique. What my tip would be, just you need to get trained and do 4-5 cases where the result may not be so good, and then get some confidence, whatever the technique.
Ashwini sir, your 2 cents on the practical application, how you would want a beginner surgeon to proceed.
When I did my first iris claw, there was complete sulcus was there. Complete sulcus. I could have easily put any multi-piece lens in the sulcus, but I did iris claw. Retrofixation, गिरेगा तो कुछ बचेगा. So in that case, and SFIL, I will say, in case as a beginners, to avoid post-vitrectomized eyes, they should avoid, because the eye will collapse. They will find it very difficult, and it will like very difficult, because you will make a 3.2 entry during delivery of the lens, to removing the haptic out. So I will suggest not to do in the initial cases to avoid SFIOL in case of post PPV cases, or to start with in case of complicated cataract or ECC cases where you can do a limited vitrectomy, and in those cases, so I will say SFIOL in that. Iris claw, I will suggest to start doing anterior fixation and do a PI first initially if you want to do a initial cases in cases, and retrofixation later on. But as I said, cataract we do day in day out, but these cases we do very rarely. So master one technique and fix to it. Because if you are good at suture, keep on doing that. There is no point of doing iris claw, and especially in the beginning stages. Once you attain a mastery, you can do as a VR surgeon. They prefer to do a SFI in most of the cases. Pantry segment surgeons, they do iris claw after some expertise. So just master one technique. I learned 2-3 techniques, different techniques, tried SFIL. I did good. Then I asked my seniors about doubts. They told me not to do that. Do one technique only, master one technique, and keep on doing that, because you are doing SFL maybe once in a while, maybe 1-2 months or 1 month I do a one SFL or not. So keep on mastering that technique. So or not until you find a technique which you feel okay, that might change the better outcome for the patient or decrease the time duration, because that surgery will have a learning curve also. That surgery will need a learning time also. So I will suggest to avoid that, these 2 points only.
Right. Thank you, sir. Aarti ma'am.
Yeah, so let's say we are talking about how to start these surgery or these secondary IOLs. First thing I will say is make sure that you know what are you going to do next day. So if you want, you can write your steps on a piece of paper, discuss that with your senior, discuss in front of your technician and tell him that what instruments you will need. Make sure that everything is there on the trolley. So if in case you are doing operating a very soft eye, you know that AC maintainer probably might help it in initial cases. So you might want to be ready with that. If you are doing a claw lens, you might want to be ready with the forceps, which you will need, which is the most important thing on your trolley that day. So make sure that you are prepared in terms of your technique and knowledge both. Then it's good idea to ask for help. So if in case you know that your VR surgeon is there, just tell him that, I'm going to do this case for the first time. And if needed, I might call you to the theater. And don't feel shy to ask for help. If in case you know that you have a senior in theater, just tell him that, son, I may call you, or ma'am, I may call you if I need you. There's no harm in asking for help when you are learning. You will learn in a proper way. Just putting the lens is not done with the surgery. It's like how you're putting it so that you're mastering it very quickly. And then the good thing is that nowadays you have wet lab in so many conferences. So, you can just choose one of the conference wherein you want to go and learn this thing, especially the claw lenses. Nowadays, it is there in almost each and every conference. You have the wet lab session. So you can go and practice there, spend your time on learning on a dummy eyes, or in case you have something available in your own hospital, then you can definitely do it. The third important thing, according to me, is follow-up of your cases. So let's say you have operated a case. You really want to follow it up and you don't want to leave it to your resident or let's say your colleague to see the follow-up of that case. Because you've done it for the first time, you want to know that, what I had struggle in putting this haptic. So probably let me see how is it today. So that way you will learn fast and you'll master it fast. And I'm sure if you are skilled, you will transfer that skill to your junior very easily. I think that's it, Anujit, from my side.
I think I'm just collecting pearls from everyone. I think we've gotten a lot of pearls right now from Zain sir about choosing the right thing, sticking to the right technique, noting your technique, asking a senior for help, asking a VR consultant to stay, asking for help at the right time. We'll move, I think I've collected 6 or 7 pearls. We'll move on to Dr. Shomova for pearl number 8 and 9, and then we'll conclude with ma'am.
So probably for secondary, probably I am doing the maximum in number amongst you because of the complication load in cataract trainees that we have. So probably 5-6 secondary IOL I do per week, and it mix up with iris claw lenses and multi-piece IOL as a secondary SF IOL. So probably after interacting with all the anterior segment surgeons and the posterior segment surgeons, my view is iris claw lens is better safe in hands with anterior segment surgeons, and it is very fast and very cheap. So for if your patient don't have any financial support, so go for iris claw lens. And for VS surgeon, it is better to go for SFIL because of the long-term stability of the IOL. And in iris claw lens, what happens is people will not dilate fully in the long run. So if the patient have any retinal issues, you will not see till aura in the post-op period. So in retinal pathology, you should go for SFILs. But the real fact is that once you are habituated with iris claw lenses, it is so fast and so easy. You will not switch to other SFILs because it is very easy and very fast. Just 2 minutes, it is finished. So probably everyone should know SFIL for its superiority in time taking, because we have some time issues in our OTs. We have other cases also. So, but for me, CMT Flex, I don't have the follow up for more than 6 months. My first case was 6 months before. So probably CMT Flex is the future. If you given a choice of choosing your secondary IOL for a premium patient who can afford anything, in aphakic uncomplicated patient, you should go for CMT Flex. It should be the future. But otherwise, iris claw is faster and SFIL is, I think, a better stable.
I think CMT Flex is also quite an easy technique to pick up for most surgeons who are conversant with iris claw, because you just go into the pars plana with a 23 gauge and pull the haptic out on each side. What is your take on its ease of transition to a CMT Flex from someone who would do an iris claw?
Not that easy.
Not that easy?
Not that easy. For a VR surgeon, it is okay because everything is in your control. You have a pars plana infusion. You don't have the issues of hypotony. So it is very easy for you, because I have shifted from cataract surgery to VR surgery. So I know that inside the vitreous cavity, cataract surgery is not very much comfortable. So it is not that easy. And another issue is that while pulling the optic haptic junction, it has a tendency to tear out. So that is a issue that you have to be very cautious. But yes, stability is very, very nice in the long run. You have to do a scleral pocket that is a little bit time taking for other than SFILs.
So in the case where the haptic tears, do you again suture from the eyelet at the optic?
No, you have to explant that.
To explant the lens.
Yes.
Okay. So for some concluding remarks, we'll move to Vanashri ma'am.
Okay, I would actually like to share some of my experiences with the iris claw, 1 or 2 tips that I would like to give. Well, when you're seeing a video of the surgery, it looks very easy. But when you're going in, as Aarti was saying, plan your steps well. And most important is the side ports that you're creating. If you're going it as a secondary procedure later on in an aphakic patient, whether you're refashioning the side ports or you're making new side ports, make them carefully so that your manipulation of the sharp iris repositor to the claws is very easy and you don't have to struggle there more. Because the moment when the struggle comes is where the enclaving will not be proper and you'll have a fisheye appearance. If you don't want a fisheye appearance and you want the pupil to be more or less circular, then it has to be planned well. And that comes very, very much important is how you plan your side port. That is one point. Second point is, after you've done many iris claws, you get, kind of confident and, you're like, okay, this is easy, I can do it. So I had this particular patient who came with a disenclavation, operated somewhere else. Iris claw was done around 2 years back, and the iris claw, one claw had disengaged. and I had taken her up for re-enclavation. Now, when I saw this patient on slit lamp, everything was fine. She was in the sitting position. So, the iris claw was roundabout in the pupillary plane, just dislocated inferiorly. But when you take this patient on table, she is supine and the iris claw bang, just goes into the vitreous cavity and you have no view of it. You only know that it is enclavated at one end. So how do you manipulate at this point? So I was struggling to fish it. And that's the time I realized this, this with that either with a dialer or with a blunt instrument, maybe like a Kruglin's hook, you have to actually slide it across to where it is enclavated and bring it up and hold it with your other hand, which requires a bit of a manipulation. So most important point here is, however confident you may be, sometimes it so happens that you may be stuck in a situation, you may need to call up some of your seniors to take help to, or even you may need a VR backup, even in case of iris claw re-enclavation cases or some difficult situations like that.
So one point I just can add in the iris claw, because I have experienced it, and it has in any YouTube video you will not find this. Just to check the patency of the claw before clipping it in the outside of the eye, because twice I have faced this situation that I have enclaved one side, and while enclaving the other side, there was actually no claw. There was a manufacturing defect, so that part was solid. So I just I had to explant the iris claw, which I have tucked in the other side, and it is very difficult to explant once you have tucked one side. So it is exactly reverse procedure. You have to go beneath the iris and you have to explant it. It is very difficult. So iris will there will be iris in here. So just check the patency of the both side of the iris claw before putting it.
And Indian models of iris claw is little rigid. Imported are like the staffing happens less because very smooth and easily happens. In Indian iris claws are rigid. I feel more rigid than imported ones.
Right. So we've had a really interesting discussion on merits and demerits of all procedures, including the article. So with that, we come towards the end of our journal club session. We'll have a small round of vote of thanks. So I would like to present a certificate to Dr. Shilpa for presenting very well a complicated topic with a lot of flaws in the article. Dr. Vanishri Nair ma'am for being the monthly mentor for the month of December. Dr. Zain for being the research expert. Dr. Ashwini, Dr. Shomovo, as well as Dr. Aarti ma'am for being panelists and sharing all their insights, including experiences from their daily life on iris claw as well as SFI. I invite you to the next session of the Journal Club, which is most likely going to be on refractive surgery. Once again, if you have enjoyed this discussion and would like to present in the Journal Club, you can take a screenshot of this or get in touch with me or Nupur ma'am or write to us at yosi.journalclub.com. With that, we come to the end of the session. I would like to thank all the panelists, the monthly mentor, the mentee, once again for cooperating, for being a part of this session.